Good afternoon, ma'am. Ma'am,
இல்ல இப்ப மைக்ரோஃபோன் ஆன் பண்ணிட்டேன். ஷல் ஐ ஸ்டார்ட்? கேமரா ஆன் பண்ணணுமா? ஆமா. ஓகே. ஷேர்.
am I audible? Hello, ma'am.
Aditya, am I audible?
Yes, ma'am, you're audible, ma'am. You're audible, ma'am.
Aditya,
Ma'am, you're audible.
am I audible?
Yes, ma'am, you're audible. Hello, ma'am.
Am I audible?
Yes, ma'am, you're audible, ma'am.
Aditya.
Ma'am, you're audible, ma'am.
Hello? Opportunity. As a biochemist, I got the topic and be clinical uncertainty. That is, radiological tests or ECG helps a clinician to confirm and to diagnose patient. The rationale of selecting, ordering, and interpreting the laboratory results helps the clinicians in diagnosing and treating the interpretation test, which is pertaining, which helps confirming the diagnosis as well as managing the condition. So this is the criteria. There is criteria to select the lab test, which helps to confirm the diagnosis. So some important principles in using the laboratory tests are under the best circumstances. So what are the circumstances you use? No test is perfect. You cannot say this test is 100% perfect because there can be changes, there can be variations depending upon the conditions of laboratory. So nobody can say 100% sensitive, 100% specificity, and the predictive value is 100%. This is the rule, thumb rule we can say. And the most sensitive tests which we use or which we select or use to rule out the suspected disease so that the number of false negative tests are minimal. So the meaning of this statement is whenever you are using a test, it should be a very sensitive test to confirm the diagnosis or to rule out the suspected disease. Most probably, if you are using a test, say this test mostly we use for example, say in conditions like carcinoma, you have to select a sensitive test which can confirm the diagnosis or which can rule out the suspected disease so that you can minimize the false negative test. That is the meaning of that statement. Coming to the next one is the specificity of the test. Whenever you are choosing a test, you should measure it again the same thing. It should either confirm or it should exclude a suspected disease so that you can minimize the false positive results. And the choice of tests should be based on prior probability of diagnosis being sought. Say you cannot order the test, almost all the tests, whatever that comes into a way. If you are suspecting some condition, you have to select the test appropriately, and then whatever there is there in the lab go for, because it is again a burden for the patient. So choice of the test should be based on probability of diagnosis. You cannot say you may ask one thing like how can you know that this can be, so there will be probability. Say for example, if you say some infection, a simple infection like a seasonal infection, flu, if you suspect dengue infection, you can choose accordingly. If you suspect malaria, you can suspect accordingly the labs. That's how the probability of diagnosis, depending upon that, the lab test should be chosen and you have to order for those tests. Blood tests are used for several reasons. So there are so many reasons why we should order for these tests: to diagnose a condition, to diagnose a disease, to rule out certain diseases, any chronic or acute conditions, and then to monitor. Hello, Aditya? Visible இல்லையா? பார்க்க முடியலையா? Okay. Okay. I'll come. Presentation is not visible. microphone. Hello, Aditya, is it visible? Is it visible? Right. Okay, shall I continue? Tests are used for several reasons, including to diagnose a condition, to rule out certain diseases, to monitor treatment plan, and to check out overall general health. So there are several rule out exams not only helps us to diagnose the disease, it also helps us to monitor the treatment plan. Above all, it is usually it becomes routine for the overall checkup of general health. So keeping all these things in mind in any point of life, so we require a blood test to rule out any condition or to diagnose any condition or to for possibly for overall general health check. This life, and it helps us not only to come to the to maintain the proper health care of the things. So interpretation of lab reports. Coming to the interpretation of lab reports, just almost all these tests are always don't say that every time when you give a sample don't expect either it should be a negative or it can be a positive, or sometimes the test may be borderline or inconclusive. The values may be numerical, it may be reactive and non-reactive. So reactive and non-reactive reports usually we give for the viral infections. Example, HIV, the reports will be given as reactive or non-reactive. It is not given as positive or negative, but it is usually interpreted as reactive and non-reactive. Sometimes some reports may be the borderline. Say for example, thyroid reports. Patients on thyroid treatment, hypothyroidism, and patients are on treatment. The reports may be on borderline, or sometimes it can be inconclusive. And even the gender. Say the reports are also there will be variations according to the gender. If the males and females, if you take the values, there will be slight variation. There won't be much variation, but there will be slight variation. So the lab reports are dependent not only on the condition of the patient but also several factors. Any abnormal result. So after seeing the lab result, don't be panic. It means that an abnormal result not always means that you are unwell, or similarly good and patient is healthy. So there might be some variations, there might be confusion. Blood tests always are perplexing to say the least. So interpretation depends upon the condition of the patient. There you can see this is a picture of complete blood count. So here in first column you can see the parameters that test like hemoglobin. Enna Aditya? Ekliya? Slide move agliya. சரி நான் உங்களுக்கு அனுப்பவா ஷேர் பண்றீங்களா? மினிமைஸா? ஜஸ்ட் மினிமைஸ் பண்ணு. The product, okay. So this is the format of showing a lab report. You can observe the parameters on left side. So these are the parameters what are all the parameters when we order. This will come on this way. And on right side you can see the reference value, which means the normal range. The units is very important because sometimes the variations may be depending upon these. Some labs may give a different unit. So you have to check before going for interpretation the units of these parameters, and then the patient details on extreme end. You can observe the date, time, and when they have been ordered and the patient's value. This will be the routine format of a lab report. So we'll see how these lab reports will be interpreted. So what does these test results mean? So with hundreds of types of laboratory tests, it is impossible to cover them all. So I'm taking only the basic tests and their interpretation. So before going for the interpretation, we should know what is this reference range means. When you are looking at the lab results, we see a common column called this reference range. This reference range is nothing but out of 95% of the total population. When you take 100% of population, most of the population, large population of 95%, which falls into this category, is considered as normal values or normal reference range. That we take as normal reference range. That we keep it as normal reference range for that particular parameter. So this range of normal values has to be determined by examining the normal test results of a large group of healthy people. That's how you have to set a normal reference range. And this normal reference range will vary depending upon the lab. Sometimes there might be very small variations. And if you see a change in these reference ranges, you have to interpret accordingly. Likewise, sometimes they may give the units differently, and you have to check what is the units, whether it is within the normal range or it is out of the range. You have to remember that every range, when the values are either side of this range, it may indicate sometimes probably a condition or a disease. A clinical laboratory test. So these tests, whatever we are doing in the laboratory, it helps us to diagnose, monitor, and screening purpose. So lots of data is provided. We get lots of information from these data, and it is useful for the clinicians to come to the conclusion. So when you see a test, when you see a result of lab report, it may be a positive result, it may be a negative result, or it can be, as I told you, an inconclusive test. A positive result means that the substance or condition being tested was found. So, for example, if you are checking for a virus, the antigen or antibody, if that antigen or antibody is present, you call that test as a positive test. This can be at higher range. A positive test can be at a higher range, or it can be at lower range. And a negative test means if that particular substance or compound is not found in the sample, if particular antigen, say for example, an antigen or antibody is not found, you can say that the test is negative. Similarly, inconclusive, that is, if you are not able to come to the conclusion, you call that as an inconclusive. In that case, you call the test as inconclusive. You have to give some more time. Again, you have to recheck whether the test is positive or negative. Almost this condition occurs when you are testing for a viral infection during the initial days. Say, for example, when a person comes with the symptoms of fever and immediately you go for a viral antigen test, sometimes the values may be inconclusive or it may be a negative test. So in order to overcome this, you have to wait for 1 or 2 days. Then you can go for the testing. Then you can see whether it is positive or negative for that particular infection. What is meant by a false positive and false negative test? Most of the time we come across these things in the lab. A false positive and a false negative. A false positive test is nothing but it shows a disease or condition even if it is not present. So, for example, most common thing which we come across is when a woman is tested for a pregnancy test, sometimes it may give a false positive test because of interfering substances, even though the pregnancy may not be confirmed by other investigations. Most probably, the investigation can be to confirm the pregnancy is ultrasonogram. So, this false positive test, to rule out this, again you have to go for the higher end of the investigations. Similarly, a false negative test, as I told you, initial stages of a viral test. If you are suspecting any viral infections, and it may give a false negative test immediately if you go for that. And this to overcome this false negative test, you have to wait for some more days and then you have to check again. A false negative test, so by definition, is nothing but the disease may not be present, or the disease may be present sometimes, but it may give false negative test. If you observe this, you can you will know, you will understand what this true positive and false positive are. So here I have given the disease and test. If disease is positive and tests are positive, we call that condition as true positive. If disease is negative, there is no disease, and test is positive, you have done the test, you call it as a false positive test. Similarly, if a disease is positive and test is negative, there is a disease condition is prevalent in the patient, but the test report shows negative, you call it as a false negative. You are creating in the patient that he is well or he is healthy. So false negative sometimes can come to the conclusion, you can come to the conclusion that the patient may be healthy. Similarly, the disease may be negative and test is also negative. Both are negative. The condition is called as true negative. So there is no chance of a disease or any condition in that patient. We call it as a true negative. So this reference range also depends upon, this may vary on depending conditions like pregnancy. If a woman is pregnant, the reference range again may vary. Similarly, the medicines which we are taking. If a particular person is on medicine, say for example, if he is on antiplatelet drugs, the person's platelet count, the platelet count may vary. The bleeding time and clotting time also may vary. It may differ from the normal reference range. Eating right before a test. So usually for taking if in order to rule out diabetes mellitus, we ask the patient not to take anything before the test. That is, fasting is the rule. So if a person takes something before the test, the test values may vary. Similarly, for checking the triglyceride levels, the patient is requested to come by fasting. If patient takes some breakfast and he gives the sample, the test results may vary. So eating right before a test also can change the values. Similarly, smoking, it affects lots of parameters, and if a person is under stress, again it can cause variations in parameters. The most affected parameters, if we see, even the blood glucose levels can change if a person is under stress. Coming to the common blood reports. Sometimes if a patient approaches a physician with a fever and symptoms of fever, nausea, vomiting or something like that, the most common parameters with which a clinician orders are the complete blood test. We will now see what this complete blood count is and how it helps us. A complete blood count is a very common clinical procedure, common lab test we can say. It helps us to detect any abnormalities of the blood, and it gives also the indication of disease present in other organs like even in the bone marrow. The components of complete blood test. If you go through the components of complete blood test, it includes the hemoglobin, RBC count, complete the WBC count, total WBC count, which include the differential count like neutrophils, lymphocytes, monocytes, eosinophils and basophils. Then the platelet count, MCHC, that is mean corpuscular hemoglobin concentration, MCH, mean corpuscular hemoglobin, and the hematocrit. So complete blood count includes all these parameters, and you should be able to interpret the normal range, and you should be able to differentiate from you should be able to diagnose by seeing the values. So the normal range, if you observe for the complete blood count, hemoglobin, as we all know, it should be between 13 to 16 grams per deciliter, or here I have mentioned 135 to 180 grams per liter. So you have to see the units also. Here it is grams per liter, so 135 to 180. If it is deciliters, it is 13 to 18 grams per deciliter. Any variation in the values, say for example, this value is almost constant in the males and the values may vary in females because the menstruation and all affects the hemoglobin values. So in case of females, it is at lower side, say around 12 to 14 or 16 grams per deciliter. And one more thing which all the students or the clinicians usually, whenever they are checking the hemoglobin in case of males, whenever there is variation in the hemoglobin concentration, it indicates some disorder, because usually there won't be any change in the hemoglobin in adult hemoglobin after particular age. If there is decrease in the hemoglobin, it immediately seeks the attention of the clinician. Next is WBC. So WBC, you can remember easily 4 to 11 into 10 to the power of 9. So 10 to the power of 9 is the constant. So 4 to 11, 4,000 to 11,000 is the which you have to remember, and any changes in these values indicates any infections or any disorders pertaining to WBC. Coming to the platelet, you can remember easily 150 to 400 into 10 to the power of 9 per liter. So usually routinely we say 150 to 400. So any changes in these platelet count, usually in case of viral infections, the values may decrease. So this helps us to diagnose the viral infections. And MCV, PCV and all these are red blood cell indices. So whenever there is variation in these concentrations of MCV or PCV, MCV should be around 78 to 100. Whenever the values are low, it indicates iron deficiency anemia, and whenever the values are high, it indicates that person is having any megaloblastic anemia or folate deficiency or B12 deficiency. Similarly, PCV, it should be around 0.4 to 0.5. An important parameter is RBC, because this RBC again plays a major role. Whenever there is decrease in RBC, usually we concentrate in decreased or lower side of RBC. It indicates again any disorders pertaining to the blood. So 4.5 to 6.5 is the normal values. It should be around an average of 5 into 10 to the power of 12 per liter. Similarly, MCH and MCHC, depending upon the concentration of RBC and hemoglobin, the MCH and MCHC values may vary. You can observe here, the units are picograms and MCHC is grams per liter. So in case of iron deficiency anemia, these MCH and MCHC concentrations may decrease. And the differential count, coming to the differential count of WBC, the neutrophils, lymphocytes, monocytes, eosinophils and basophils. Whenever there is infections, the neutrophil count may decrease. If it is viral infection, it is decreased. If it is any bacterial infection, the neutrophil count may increase. Similarly, the lymphocytosis, monocytosis and the eosinophils. Eosinophils, the most common thing is during allergic diseases and parasitic or any fungal infections, the eosinophil count may increase. And basophils, any myeloproliferative disorders, we can see the basophils in peripheral sphere. So whenever a complete blood count is ordered, you have to check all these parameters and you have to go through the normal values, and any variation in these normal values, you can interpret the condition accordingly. And this is the device for complete blood count, where a peripheral smear is drawn and it is then just when you take this slide and when you check, you can get the automated complete blood count. Nowadays it has become an automated count, and there won't be any much variation in the count also. So as I told you, the variations in the RBC count, any deficiency of, when you see the lower side of RBC count, it should be 4.5 to, remember 4.5 to 6. Whenever the values are less than 4.5, it indicates excess bleeding. or RBCs are not synthesized properly, or whatever the RBCs has been synthesized or produced, it has been undergoing the lysis quickly. Can be hemolytic anemia or conditions like hereditary spherocytosis. Similarly, whenever you see the RBC count are more than 6 millions, it can be because of primary polycythemia or secondary polycythemia. The secondary polycythemia, again, it can be because of conditions like pathological conditions. We can say the congenital heart diseases, or sometimes at higher altitudes you can see the RBC count is more. The variations, if you come to the variations of WBC, I have told you so many the fractions of WBC, the like lymphocytes, neutrophils, basophils, monocytes, and eosinophils. So whenever the total count of WBC is decreased, you call that condition as leukopenia, decrease in WBC. Whenever the neutrophils are decreased, we call it as neutropenia, and it helps us to diagnose the conditions like typhoid, any bacterial infections, typhoid fever, or aplastic anemia, or when a person is taking the chemotherapy, the neutrophil count is decreased. The reason why the neutrophils are decreased is nothing but they helps to fight against the infections. That's why the neutrophil count is decreased. Basopenia, whenever the basophil count is decreased, usually you see this condition in hypersensitivity or acute allergic condition, the basophil count is decreased, and thyrotoxicosis. Lymphocytopenia, whenever the lymphocytes are decreased, this is again we can see in viral infections as well as systemic lupus erythematosus, rheumatoid arthritis, and myasthenia gravis. So these are the minute, even though you think these are the minute or small information, but still it gives us a large conclusion. You can come to the conclusion when you observe closely, when you go for other investigations simultaneously, you can immediately diagnose the conditions. The monocytosis or monocytopenia, you can see in tuberculous conditions, especially the mycobacterium avium and mycobacterium tuberculosis, and in certain fungi, the monocyte conditions, monocytes are decreased. In elevated blood cells, when you see the WBC count is increased, you call it as leukocytosis. So naturally the neutrophil count is increased, the basophils are increased, so as to hypothyroidism, and in myeloproliferative diseases the basophil count is increased. Eosinophilia, whenever the fungal diseases or parasitic infections, and most commonly in allergic conditions, seasonal allergies, the eosinophil count is increased. So monocytosis, again they are increased in sarcoidosis and autoimmune disorders. So this gives us a complete blood count, and interpretation will help us to come to some extent, I can say, to the diagnosis. Platelets, again, nowadays, since the seasonal variations and so many infections coming into this during these seasons, so we have seen the corona period also. Usually during the viral infections, most commonly the platelet count is decreased. Any viral infection, for that sake, either it can be a coronavirus or a dengue virus or any other virus, if you observe the platelet count is decreased. So deficiency of platelets is usually, you call it that condition as thrombocytopenia. Apart from that, there are so many other congenital hereditary conditions which may cause platelet count, decrease in platelet count. And elevation in platelet count is seen in conditions like acute bleeding, cancers, infections, and patients on usually there are hereditary conditions where the platelet count is increased and they're more prone for clotting disorders also. And in that case, antiplatelet medications are given. You call that condition as thrombocytosis. The other tests which we usually do in the lab are the prothrombin time. This is the most common test which we do, because when any patient is posted for surgery, the most common parameter which normally the physicians requests are the prothrombin time, which is around 9 to 11 seconds. This is the time which takes for the blood to clot, and it should not increase, because if it is increasing means there is more chance of clotting for that patient. And this usually the abnormal results you can see with the disorders like hemophilia, liver diseases, or any malabsorption conditions. So, and patients on warfarin or patients who are taking the antiplatelets, they can be monitored by using this parameter prothrombin time. And fibrinogen, the fibrinogen levels should be around 200 to 300 milligrams per deciliter, and any signs of excessive bleeding or hemorrhage or any disseminated intravascular coagulation, the fibrinogen levels will be, they may vary and it may cause sometimes the clotting. The next parameter which you have to concentrate is the heme case of children as well as in adults, because most of the leukemias in children, the patient may present with very low hemoglobin. Condition might be almost has come to a first or second stage. In that condition, the hemoglobin is the first parameter which will show lots of variation. So there are different conditions like normocytic where the hemoglobin levels are decreased but RBC size is normal. And this is the most common condition which we see in females. The iron deficiency anemia and the peripheral smear shows microcytic anemia. And macrocytic anemia, deficiency of vitamin B12 or folic acid can cause macrocytic anemia. Apart from that, the alcoholism and hypothyroidism, because in alcoholism it is because of deficiency of vitamin B12 and folic acid which causes macrocyte. The cells will be larger in size but hemoglobin concentration is again decreased. And sickle cell anemia, this might be a little in our Asian population it might be less. Nowadays we are seeing even sickle cell anemia most commonly. This is because, as you all know, alteration in hemoglobin structure, there is mutation in the globin chain at 6th position causing sickle cells. These are the variations in hemoglobin. Coming to the most common laboratory tests for cardiovascular system, here I am dealing with only the emergency conditions, because most of the time to the lab during any acute conditions, the physicians will be requesting for these tests. The most common test is the CKMB, which helps us to clinch to the diagnosis of acute myocardial infarction. So creatine kinase, the total creatine kinase will be around 400 to 600 international units per liter. So if you take forms, helps us to diagnose different conditions. So in case of myocardial infarction, it is CKMB, which helps us to diagnose immediately along with the ECG. So the normal levels always, it should be less than 120 or it should be around 150 in case of males. Whenever the values are in case of MI, the values may go up high, and it can help us to diagnose myocardial infarction. Apart from creatine kinase, troponin. So cardiac troponin T and cardiac troponin I, it gives us the sensitivity of these troponin is about 85 to 90%. Both these troponin T and I can help us even before CKMB rises. The troponin can show immediate rise immediately after after having a heart attack. So troponin I and T and CKMB are the emergency tests which we do routinely to confirm the myocardial infarction. And B-type natriuretic peptide test, it can help us to diagnose the cardiac conditions like heart failure, and C-reactive protein, any rheumatoid fevers and any inflammation in the heart. And similarly, a patient is having stroke or any vascular disease, this C-reactive protein helps. A routine lipid profile. If you check a lab report, you can see the lipid profile, the heading lipid profile, which includes the total cholesterol, triglycerides, HDL and LDL. So this helps us to know the condition, the cardiovascular condition, the lipids profile, how the system is and how the patient's condition is, whether he is having any trouble with the arterial system, whether there is any clots. All these things can give us some information, even though it is not 100% we can say. So always, for the sake, any person should check the lipid profile. At least this should be a routine after 40 years of age, because this lipid profile, if a person is having any variations in this lipid profile, it helps us to diagnose the earlier any heart disease, any risk factors for the heart disease. So the first and foremost I could say is total cholesterol. The normal levels should be less than 200 milligrams per deciliter. This is the desirable, and nowadays even they say it should be less than 150 milligrams is desirable, the total cholesterol, and 200 to 230 is the borderline, and above 230 and 240 is very high. Even we have seen the cases above 500 or 600 with the cholesterol levels, and sometimes they may present with symptoms, sometimes they may not present with any symptoms. Coming to the triglyceride level, this is the most important parameter which we have to check when a patient with any abnormalities of heart, any symptoms or any conditions of diabetes mellitus or heart disease. If they present, the triglyceride levels will teach us to the or will helps us to monitor the condition. So the normal levels should always be less than 150 milligrams per deciliter is the desirable one, and 150 to 200 is borderline high. 200 to 500 is high, and above 500 we can say it's very very high, and which the interference there should be an immediate interference. The next parameter is LDL cholesterol, and less than 100 milligrams per deciliter is the desirable, is the optimal one. Nowadays they say it should be always less than 100 milligrams for a diabetic patient, and when the values are very between 100 to 129, immediately the physicians they try to start some statins. So near optimal or above optimal is 100 to 129, 130 to 159 is borderline high, and 160 to 189 is high. Above 199 is considered as very high. Coming to the last but not least, the HDL cholesterol level, we call it as a good cholesterol. So the values should be above the 60 milligrams in a normal person. When the values are above 60 milligrams, it is considered as the even though we say with the protective against heart disease, but still 60 milligrams per deciliter we can say a normal good cholesterol is considerably high. And 40 to 59, the higher the better. So you have to go in this order for HDL cholesterol. So less than 40 is again a risk factor for heart disease. So patients with less than 40, they have to check regularly whether their cholesterol levels are coming to the normal. Next is in the lab format, you can see the liver function test. Under this panel, you can see a list of parameters. So liver has got the synthetic function. It synthesizes the proteins, it synthesizes the albumin, globulin, and Aditya கேக்கலையா? ஹெமட்டாலஜிலே இருக்கா? மூவ் ஆகலையா? இப்போ லிவர் ஃபங்க்ஷன் டெஸ்ட் போயிட்டு இருக்கேன். மறுபடியா? ஒரே நிமிஷம் செக் பண்றேன். ஹெமட்டாலஜி ஸ்லைட்லயே இருக்கா? எங்கேயோ இருக்கு, மூவே ஆகல. ஃபர்ஸ்ட் டெஸ்ட் LFT. So, the battery of tests for liver functions are the enzymes like ALT, alanine transaminase, The normal values are around 35, it is also around 35 to 40 international units per liter. Then ALP, the alkaline phosphatase, it should be around 120 milligrams per deciliter. Bilirubin, as you all know, it should be 0.2 to 1 milligram. The total bilirubin should be 0.2 to 1 milligram per deciliter. Albumin, it should be 3.5 to 5 grams per deciliter, and it indicates the synthetic function, whether the liver is good, it is synthesizing properly. By you can know by checking the albumin levels. Similarly, the gamma glutamyl transpeptidase GGT, it should be around 120 milligrams per deciliter. So GGT helps us whether the person is having healthy liver. In case of alcoholic liver disease, the GGT levels are very high. So AST and ALT, the AST levels are increased not only in liver diseases but also in case of any changes in the heart or any heart diseases. AST of students, I just want to say the AST and ALT levels drastically increases in case of hepatitis even before you see changes in the bilirubin. So it reaches the values like 2000 to 3000 international units per liter because of so much of damage to the hepatocytes. The liver enzymes are released into the circulation. So AST and ALT levels can reach up to 2000 to 3000 in case of hepatic jaundice, and bilirubin levels simultaneously depending upon the condition. Both the conjugated and unconjugated bilirubin levels are increased. Coming to the alkaline phosphatase, whenever the levels are very high, it indicates there is some disease in the biliary tract. Now, or sometimes in growing children, the ALP levels are elevated. I think most of you might know that in rickets in the bone or some placenta can also cause changes in the ALP levels. And gamma glutamyl transpeptidase indicates the liver disease, whether a person is alcoholic or not. And ALP can join any viral infections, hepatitis A or hepatitis B, the bilirubin will be increasing. These are the common things. As students, all of you should know how to interpret all these the parameters of liver function test. The most common parameter is the most common lab test which the physicians order is the renal function test. Under this category, you can see the serum creatinine. All of you know, in the serum creatinine will be changing drastically whenever the kidney functions are affected. The normal value should be around 0.6 to 1.1 in case of females, and around 1.3. It should be around 0.7 to 1.3 milli. See, one thing I want to tell to the students here is, if even though the values are say 0.7 to 1.3 milligrams per deciliter, the desirable values for a healthy person should be around 1. It should be less than 1, or it should be around 1 in case of males, and in case of females it should be around 0.8 or 0.9, something like that. Whenever, say for example, if a person is around 40 or 45 and his creatinine values are at higher range, we call it as higher range 1.3, again it indicates disease, again it indicates some disturbances in renal functions. So always don't stick to the normal range. It depends again on age also. In case of older people, say around 70 or 80, if a person comes with creatinine 1.2 or 1.3, for that age it is okay. But a person with 40 or 45, if he got the creatinine around 1.3, it indicates there is renal dysfunction. Serum creatinine, next comes the routine parameter. As you all know, the urea and uric acid. Urea should be around 30 to 40 milligrams per deciliter. So in case of any CKD or AKI, acute kidney injury, both urea and creatinine values changes accordingly. Urea, creatinine and uric acid. This is the renal profile which is normally done in the lab to assess the renal functions. Uric acid should be around 3 to 5 milligrams per deciliter. Coming to the creatinine clearance, the importance of creatinine clearance here is, it is the clearance, as we all know, it is the amount of creatinine that gets cleared off from the kidney ml per minute. So each and every amount ml of blood that clears off the creatinine from the blood is called as creatinine clearance, and it should be equivalent to GFR. Around 125 ml per minute is the normal creatinine clearance. Another significance of creatinine clearance is, even before you see the changes in the creatinine, even if before you observe the changes in the serum creatinine values, there will be change in the creatinine clearance. If the values are less than 80 or 90 in case of males and females, it indicates again renal dysfunction. It might be stage 1 or stage 2 depending upon the creatinine clearance. For the creatinine clearance, you have to request the patient for the 24 hours urine sample, as well as the patient has to give his serum creatinine to estimate the creatinine clearance. And again, urine albumin, absolutely there should not be any albumin should not be present in the urine in a healthy conditions, but still in some physiological conditions as well as pathological conditions, you can see the presence of albumin in the urine sample. And some labs, they report BUN. BUN is nothing but blood urea nitrogen. It is half of the urea levels. I told you the urea levels are around 20 to 40 milligrams per deciliter. So exactly half is the blood urea nitrogen. You call it simply as BUN. So either of these things can be okay. Next important parameter to assess the renal function is urine microalbumin. Remember, microalbumin should be very, very less in the urine in a normal healthy person. Whenever the values are above 30 milligrams, you call the condition as microalbuminuria, and it may mean early CKD, and more than 300 milligrams indicates a frank proteinuria, and patient is going for CKD or chronic kidney disease. So microalbumin should be a routine parameter in all the diabetic patients, because they may go for the complications of diabetic nephropathy. Next is, some labs also check albumin to creatinine ratio, which should be for it is usually represented as ratio, and it should be around less than 30 milligrams per grams. Apart from these routine parameters, sometimes the electrolytes, sodium, potassium, bicarbonate ions, are usually requested from the ICU to check whether the patient is having any abnormality. Usually the potassium levels will change in any CKD conditions. It should be around 3.5 to 5 millimoles per liter, and in any renal dysfunction, you might have seen there will be increased potassium levels, because whenever the potassium is not under control, it can lead to arrhythmias, finally to cardiac arrest. So always remember, when a patient is on dialysis or whenever a patient is with a CKD, the routine potassium monitoring of potassium is very important. Similarly, sodium should be around that 135 to 145 milliequivalents per liter or millimoles per liter, and it will vary depending upon the condition. It may increase in severe dehydration, or whenever conditions like diabetes insipidus or GI losses, it may vary. Bicarbonate, these bicarbonate levels in case of diabetic metabolic acidosis or diabetic ketoacidosis, estimation of bicarbonate levels are very important, which should be around 22 to 28 millimoles per liter. So bicarbonate levels not only in metabolic acidosis, but it also helps us to check the acid-base balance, especially when the patient is going for any compensatory mechanisms. Calcium, it should be around 9 to 11 milligrams per deciliter. So there are various conditions where the calcium levels can also change, especially when patient is undergoing any surgery for hypothyroidism. Accidentally, whenever the parathyroid gland is resected, it can cause variation in the calcium levels. Chlorides and phosphorus, all these are related to both for the kidney functions as well as whenever the patient is in an ICU. All these parameters has to be requested and usually are monitored. So I have discussed all these things, the blood urea nitrogen and the urea clearance test. We don't do the urea clearance, but we prefer only the creatinine clearance. Laboratory tests for diabetes. So usually the routine test, whenever you suspect diabetes in a patient, the routine tests like fasting and postprandial blood glucose are ordered. The fasting should be around 8 to 10 hours of fasting is required, and normal levels should be around 70 to 100 milligrams per deciliter. And if the values are between, say nowadays it has come down to 70 to 99 and 100 to 125, you call that condition as pre-diabetes because the values are borderline. It comes as pre-diabetic condition. 126 is the cutoff for diabetes. 126 and above, you call that condition as diabetes. So when the values shows these things, when the values are inconclusive, say between 100 to 125, again you can order for GTT, that is oral glucose tolerance test. So oral glucose tolerance test, whenever the values are inconclusive, whenever the values are confusing, you can go for glucose tolerance test where you give 75 grams of glucose in 250 ml of water, and you have to take the sample. Fasting sample has to be taken after 1 hour and after 2 hours. Both urine sample and as well as the blood sample has to be drawn from the patient, and you can accordingly you can check whether the patient is pre-diabetic or diabetes or usually for gestational diabetes the GTT is done. Even though it is not 75 grams, nowadays they have restricted to 50 grams of glucose because the pregnant ladies, they cannot tolerate. So glucose challenge test is done in pregnant ladies to rule out gestational diabetes. So these are the values for pre-diabetes, and for the diabetes it should be, remember, 126 and above in fasting and 200 and above in postprandial. You call it as a condition of diabetes. HbA1c, as you all know, glycated hemoglobin, also called as HbA1c. The advantages of HbA1c is it helps us to monitor the treatment. It will not depend upon on the fasting, or you can give the sample randomly whenever you want to check the condition, whether the patient is under control or not. You can take the sample randomly. It does not depend upon the food, it does not depend upon the medications, or it will not vary with the exercise, because once the glucose goes and adapts to hemoglobin throughout the lifespan of RBC, it will be there. So for 120 days or for minimal 3 months, we get the value of whether the person is under control or not. Here you can see the marks, the red, yellow and green. Normal is around less than 5.7%. You can say normal. A person with pre-diabetes, the values of HbA1c should be around 5.7 to 6.4%. And when the person is controlling fairly, it should be around 7. Not under control or poor control means 8 and above. You call that condition as poor control of diabetes mellitus. So the advantage of HbA1c is you can monitor the treatment, you can monitor the patient whether he is taking the medications properly or not. So thyroid gland laboratory test. So we know the two conditions, hypothyroidism and hyperthyroidism. The routine parameters to check the thyroid function tests are TSH. The normal should be around 0.4 to 4 milliunits per liter. Previously it used to be 5, now it has been decreased to 4. Again there is a change. FT4 should be around 9 to 25 picomoles per liter, and FT3 around 3.5 to 7.8 picomoles per liter. So whenever the TSH is high and FT3 and FT4 are low, you call that condition as hypothyroidism. Alternatively, it is hyperthyroidism. And again, nowadays it has become routine for most of the time vitamin D, because it has got a major role in so many diseases. So Vitamin D is also again investigated. The normal range should be around 30 to 74 nanograms per liter. And vitamin B12, in case of neuropathy, any suspected neuropathy, vitamin B12 is again requested. The normal values, depending upon the age, there will be variation. Adults should have around 2.4 micrograms, and in case of pregnancy 2.6, and in case of breastfeeding 2.8 micrograms per day is required. So deficiency of vitamin B12. Whenever the vitamin B12 is low, you have to rule out all these. You can rule out all these conditions like atrophic gastritis, pernicious anemia, and Crohn's disease, and so many malabsorption syndromes. The other blood tests are follicle stimulating hormone. The normal values should be around 5 to 20 milli international units per liter. Then progesterone around 3 nanograms per ml, and prolactin. All these hormone tests or hormone assays are used in case of infertility. Either it can be primary or secondary infertility, or any PCODs, polycystic ovarian disease, or any other conditions pertaining to the female reproductive system. The follicle stimulating hormone, FSH, LH, progesterone, and prolactin. Prolactin not only to rule out any infertility, it is also it helps us to rule out any tumors in the brain. So high prolactin levels are also sometimes in pituitary tumors. So these are the values around 4424 milli international units in case of males, and 530 milli international units per liter in case of females is the range. The other blood tests like DHEAS, this is not routinely, but in PCOS, this is usually ordered whether there is any changes in the hormonal system. And similarly, beta HCG, usually in case of pregnancy, early changes in pregnancy, you can see the chart. The values may vary. Normal levels should be around less than 5, and in case of pregnancy, it increases above 25. Depending upon the number of weeks, the levels of HCG may vary. And in case of autoimmune conditions, autoimmune diseases, these parameters like rheumatoid factor, lupus anticoagulant, antinuclear antibodies, and ESRs are requested. And disease marker tests are alpha fetoprotein and prostate specific antigen. In case of tumors like prostatic tumors, PSA is requested, and alpha fetoprotein levels to rule out any carcinoma. So these are the routine lab tests which are commonly requested by physician, and I hope this helps the students, the student community to diagnose, to come to the conclusion easily. Thank you for the opportunity. Hope at least finally students can catch up with this information. Thanks Aditya for giving me the opportunity. Thank you.
Thank you so much, ma'am, for joining us. Hello, sir. So we can start, sir.
Hello.
Sir, am I audible, sir?
Audible. I'm audible, Aditya.
Yeah, sir, you're audible, sir.
Yeah, okay. Can I share?
Yes, sir, you can start sharing, sir.
Indova. Is the screen visible?
Yeah, sir, it's visible, sir.
Is the slide moving?
No, sir.
Now moving.
It's moving, sir. It's moving, sir.
Now to enlarge it. Wait. Now is it moving? Aditya. Aditya.
Yes, sir, it's moving, sir. It's moving, sir. We can start, sir.
Yeah.
Yes, sir.
No, okay. Okay, I think all the audience are students, right?
Yes, sir. Everyone here are students, sir.
Okay. Okay, good evening, students. Today I will be discussing on how to write a research paper. So don't worry, this will not be very elaborative, just a sensitization. Being medical students, just to know what about the research paper and how to approach it. So it's not going to be like a publishing a PhD topic like that. So with this introduction, I will go into the topic, how to write a research paper. Yeah, my specific learning objectives will be, so by the end of the session, you will have an idea why students are necessary to do research, what are the difficulties you will be facing.
Slide is not moving, sir. It's okay now. Yes. Perfect.
Okay. So difficulties, which topic? Why I am not able to enlarge it? Slideshow, whatever. Sir, okay. I'm moving, right?
Yes, sir. Perfect,
Yeah,
sir.
okay. So which topic to choose? So now once you decided, you know the difficulties, what are the research, you came out of that, you are comparing. These are the things, difficulties in research, but I have to do research. Finally, you take a decision that we have to do something on research. Then comes the question, which topic to choose? So that also I will discuss. And once you decide to choose the topic, how to write that research topic. That is a mnemonic, IMBRAD, introduction, methods, results and discussions. That also will discuss. So I will be going in order. Why research? What are the difficulties you medical students will face? Which topic you want to choose, or which topic it is better to choose for you? And once you choose the topic, how to write a research article on that. And once you finish writing, it's not over. Where to publish that article and which journal will be better. In that I will be discussing about impact factor of a journal and how to publish. So one question is where to publish, in which journal you have to publish. Once you decide a journal which you like to publish that written article, how to publish that. So what will be the rules and regulations to publish, and how to attract the reviewers and editors. Reviewers and editors are the journal which you are going to publish. And last but not the least, the STS project. Most of the students might be knowing about the short-term studentship project, which is funded by our ICMR, Indian Council of Medical Research. All the medical students are eligible for doing the STS project, but selection will be very, very less minimum. That also I will give an idea like how your project can be get selected among the various medical colleges participating in that project. Yeah, research. So what is research? Research. So already it is written there. I want to search it again so that the research what you are doing is going to be specific. I will again read it out. It is an intensive search. The research, it is an intensive search with the purpose of becoming certain. So you want to find the findings and give a solution that this is certain. These are my findings. Your findings are not this or that. It is certain. That is called a research. So that's why the use of research, and it is a systematic investigation into reality to gain knowledge. Now, what are the difficulties? Yeah, we all know being MBBS students, it is already very demanding to learn huge volume of material. Yes, for you will have class exams, assessment exams, board exams, clinical rotations. For example, if you are a first year student, anatomy, physiology, biochemistry, guide and anatomy book, lot of things are there. Apart from that, you have to dedicate some time for research. So these are the difficulties. the common things people face. And obviously research experience is zero for first year MBBS students. You don't have any idea about what is research, but you want to do some research. So these are the difficulties, common difficulties faced by the students. They are writing a research paper itself, you find it as too much research, and you might feel that passing exam itself is going to be difficult. Why I want to do research? So all these things will run in students' mind. But what are the benefits regarding research done by the students? Yeah, definitely you will have research experience. And there are various studies already telling that apart from your studies, when you're going to do some extracurricular activities, that adds to your brain boosting metabolism. So one extracurricular activity can be research, not only extracurricular. And I'll just read out. In case if you're going to do ICMR STS project, that adds to your CV, curriculum vitae. So if your CV is very good, it will be of future, especially when you are going to do foreign degrees like USMLE. In fact, for USMLE, you require a paper publication even during your student life. If anyone who is now attending also, if you are having an aim to either go for PLAB in UK or USMLE, definitely you need to have some paper publication while you are student itself. Not necessary that you have to publish only after becoming staffs or only after doing PG. Even in your UG life, you have to do that. And once you are enrolled into the ICMR project, STS project, you will get a certificate and stipend also will be given for doing that. This is regarding ICMR. But apart from ICMR, I told ICMR is very difficult for the paper to get accepted. But you can, on your own self, with the help of your guide, you can do a co-curricular activity. That is one of the important things. You can develop your soft skills apart from just reading textbooks. It adds to your CV, especially when you're applying as a foreign postgraduate. Definitely it increases your career, completing a thesis. And obviously PG thesis is nothing but a little bit more version of the research which you do in usual life. So if you are going to do research in usual life itself, it will be very easy for you